Good afternoon. I'm Jeff Cleaver, the Executive Director of the Business Healthcare Group, and welcome to our 20th anniversary celebration. It's incredible that this is actually our 20th year. When you think of all of the milestones that we've been able to accomplish throughout those 20 years. Now, on the board in the very back, we have a detailed list of accomplishments by different years and by different categories. And I would encourage all of you to take a look at that list. And it really does show what this coalition has been able to accomplish. And it's truly not the coalition that has driven these accomplishments, though. It's all of the different individuals who have contributed to the success of the Business Healthcare Group. And what we've been able to do for the business community, for employers and employees and dependents. So if you think back, and I'm going to, and I'll rehash this, but if you think back to when Don Davis and Mary Jane Hall started the coalition, the cost of healthcare in southeastern Wisconsin was the highest in the United States, higher than New York, higher than New Jersey, Los Angeles. And Don, in his infinite wisdom, knew that if something wasn't done, what would occur is that businesses would end up leaving not only southeastern Wisconsin, but also eastern Wisconsin. So Don assembled a who's who of CEOs, and they started the Business Healthcare Group. Now, there have, again, been significant milestones, and the first group that I really want to recognize are the health systems and provider groups that have assisted the Business Healthcare Group and also our member employers and all of the other stakeholders that I mentioned in moving forward the solution to improve not only the cost efficiency of care, but also the quality of care being delivered in southeastern Wisconsin and eastern Wisconsin. So with that, let's give a hand to the health systems and provider groups. So the C-suite champions, besides Don Davis and Mary Jane Hall, evolved into a core group of CEOs. So Paul Purcell, Steve Smith, Paul Purcell from Baird, Steve Smith from Journal Communications, Keith Nosbush from Rockwell, Todd Teskey from Briggs & Stratton, and Rich Musin from Badger Meter. And I'm sure there are a number, and I do have to apologize for this, there are a number of other CEOs, CFOs, and CROs that I've missed in describing that core group, but they were the ones that really drove the solution forward initially when it was started. In addition to that, Diane, please stand up. The first executive director of the Business Healthcare Group is with us this afternoon, and it's Diane Keel. And once again, I have immense gratitude for what Diane did to move forward the success of this organization during her tenure. So Diane. Okay, now I'm going to go through this really quickly. Past the first steering committee members, and I'm going to ask you to stand, because there are stories behind many of you, which I won't go into detail. Okay, Paul Renard, and please stay standing. Dan Harmson, Jim Sharan, Paul Prickett. Paul, not here, okay. Mike Toy, not here. Craig Reynolds, obviously here. Terry Carpenter, Barbara Thody, and Frank Passetti, not here. So one of the keys about these individuals and the first steering committee, and under Diane's guidance, was their decision to partner with Humana, right, as the first single medical plan administrator, and then also to put into place what we call the high performance solution. It was high performance in name only, because what we ended up doing was taking out one of the health systems. It had no quality component, but was it successful? Very successful. And it was because of their vision that we were able to move that forward from approximately 2006 until 12/31 of 2015. So thank all of you for once again contributing to that success. Now, it's really too bad Frank isn't here, because Frank was instrumental in a decision that the next steering committee members were involved in. So Dennis, Maureen, Kenny D. Harlan, yep. Lisa, Linda Bloomer, Dan Velliser was called away, Janet Lucas Taylor, Monica Hinnick, I think Monica, yep, okay, thank you, and then Carla Nelson. So this is effectively our current steering committee member, but there is a story about Frank Passetti that I do have to relate, and that is we were evaluating Optum versus Navitus for a pharmacy benefit manager. And Frank, for those of you who know Frank, in his own special way, gave us some very special guidance in this meeting. And Frank was with the city of Kenosha, and Frank really pushed the steering committee to make this decision, and that was to move from Optum to Navitus. And Frank was with the city of Kenosha, and they had 865 employees, and in the first year, they saved $750,000. And we've seen similar success for other employers who have moved from Optum and CVS and ESI to Navitus. Now, the steering committee members that you see standing in front of you made a monumental decision approximately 4 years ago. And what that decision was is that they came and said, look, the status quo is unacceptable. We cannot sustain the expense that we're going through. So we retained the services of 3 consulting houses, and Hewitt, Mercer, and Willis Towers Watson. And they all came back with the same recommendation, and that recommendation was to put into place a high-performance primary care-centric model. And they all came back with the same recommendation on their own. So then the next question was, and that was a unanimous decision to move that forward. The next decision that this group that is standing in front of you had to make was who's going to administer that. Went to UHC, that became evident, that was a no-go. Anthem, others. And 2 of them came up with the same recommendation. And who was recommended? Centivo. And that's who we have today as our single medical plan administrator. And I'll go through some of the success that we've enjoyed shortly. But that was an incredibly difficult decision that this group made to move that decision forward. So once again, thank all of them. Okay, and I'm going to have to go through this really quickly. Other individuals that have been instrumental in the success of our organization, and Larry Rambo, he's not here. Chris Seymour, please stand up. Chris was with Humana, and thank you, Chris, for the partnership from the inception through 12/15. Jeff Black isn't here, Rose Nelson, Scott Welts. Scott, are you here? Scott's not here. He was with Milliman and Keith Kiefer. They did the first 2 studies that were founded by the Greater Milwaukee Business Foundation on Health that Craig Reynolds and Terry Carpenter were instrumental in. Leslie Dix, Steve Booth, and numerous other CEOs, CFOs, and CHROs were instrumental in the success. Leslie Dixon, Lori Lorenz, Bonnie Honesty, Kara Olson, Bonnie Ryan, Bethany Calamer, Jamie Langlois, Todd Smizel, you're here, please stand. And Todd has been, Todd? Sorry. And Todd has really been, and this is not, and this is a bit of an understatement, but Todd has been a visionary for the organization. So we have a great deal amount of gratitude that we owe Todd for what he's contributed to BHCG. And then also member employers, right? And you can't discount this as Charter Manufacturing Company, one of the founding members, BMO, Baird, Children's, Kohler, Northwestern Mutual, Rockwell, Bemis, Direct Supply, City of Kenosha Coals, and many others. And then finally, Ron Dix, and then the Right Source, Mary and Mike Rohde. And then there's an organization that has performed 2, we call it the GNS Physician Value Study, 2 iterations of that study, and that was driven by an individual by the name of Dr. Earl Steinberg. An incredible man. So with that, talked about Centivo, right? And the decision to move from our prior single medical plan administrator, approximately 19 of 2020. And after the first year, you can see what the results are for Centivo, and these results are truly impactful. So they're, in the first year, the increase in primary care visits through the primary care centric model, it was a 35% increase in primary care visits, a 15% increase in specialist visits, 8% reduction in patient admissions, 17% fewer ER visits, and Ashok will, in his remarks following me, will talk about the affordability. And it's not only affordable, more affordable for employers, even more so it's more affordable for employees and their dependents. How many families do you know that are struggling to meet their health care expense, right? And that could include even going into bankruptcy because of what they have to incur. So more affordable, 23% lower total cost of care, 14% reduction in the health plan spend, and then 14% savings in member out-of-pocket expense. Real numbers. And those are the numbers that have been attained by our member employers. So there's an employer that's not in the room, their broker is with us. For 2023, the results are a 9% reduction in the total overall spend for that employer. So membership growth, 18% between 23 and 24. And we expect incredible, significant growth for 24 and 25. So the selling season, 4-1, 7-1, 9-1s, and then obviously 1-1s. And then we accomplished network expansion this year. Door County Medical, SSM up in Fond du Lac, and we certainly expect to have significant expansion during the course of 24. So more to come. And then change is possible. I've effectively gone through this, and I'm well over my time. So with that, I'm going to invite Ashok Subramanian, the founder and CEO of Centivo, to address you.
I didn't realize this comes with housekeeping services. Thanks, Jeff. So Dave just told me, I think most of you know Dave Osendorf, he just told me that he translated some of those numbers to Jeff at Beer 30. So it's actually 80% membership growth, not 18, for the record. So Jeff, you should take even a bigger bow than you have. So look, when I listened to you describe the process that the ESC went through to choose the decision to move forward with a high-performance solution and to choose Centivo, all I can hear when you say that is we're the only people crazy enough to say yes. Now, I'm thankful that we were the only ones crazy enough to say yes, because ultimately it's your vision that we said yes to. This is not a Centivo solution. This is a business community solution. It's been authored by this group, by the leadership here, a solution that is rooted in the power of data that showed that not all providers are created equal, that we're not looking to restrict care, but we're looking to raise the bar on what's possible, and pairing the power of the data and those insights with the courage to actually take action against those insights. Those are two words that are rarely used in healthcare purchasing in America: power and courage. But this community, this business community, this provider community, by being willing to think differently and to have honest, transparent, and authentic conversations with doctors, with caregivers, with employees, with family members, the willingness to take that project on is what's led to the results that we've seen so far. And what's so inspiring to me is to be able to come back and to be able to have the conversation of the vision and the ideas of a couple of years ago, and now to see results and to hear stories. And we'll talk through some of those stories, stories of employers, stories of people who just want to come to work every day, do a great job, and not be debilitated by the anxiety of not knowing where to go for care, or not knowing if they're going to choose a clinician that is the right clinician for the care that they need, or worst of all, not being able to afford a bill that shows up in the mail and wondering what expense they're going to scrimp on in order to cover it. Those are the real life challenges that this group in this community is helping to address. And we're proud to be a very, very, very small part of that answer. So being a community solution, the bedrock of it are the providers in the community, 14,000 growing and strong. We're proud to have so many of you in the room with us today, as well as our partners from HPS. And we're proud to see, as Jeff noted, that list growing. This is a testament, I think, to the willingness to challenge status quo thinking that all sides of the equation are not willing to think differently. In fact, they all are. And we've proven that here with the types of provider engagement that's not a one and done. That's an ongoing conversation around improvement in cost and quality through forums such as the joint operating committees that the BHCG has set up. You know, in less than 2 years since launch, we now have 35 employers in this market on this program and growing, literally seeing now multiple new employers joining per week. About 50% of those employers have joined in the last 6 months. The two things that make me most proud of this list, sample list of logos, the first is that if we were to literally open a business museum dedicated to industry here in Wisconsin, is there an iconic brand? Maybe one, Harley-Davidson, but is there more than one iconic brand missing? Probably not. The depth of organizations who are committed to this community, several of whom are family-owned, and have said that it is our duty, our responsibility to not just lower costs, but to improve quality, is special. It's not something that's happening around the country, but it is happening here. The second is, if you look at that list, we span organizations together that are Fortune 500, Fortune 100, all the way to organizations with 25 employees. This is not a solution that's restricted or limited to the healthcare elite who can access anything and everything. This is built for everybody. And you see it in the types of organizations joining and the types of benefit advisors, brokers, consultants, many of whom are in this room, who are helping their clients see new ways of operating through the BHCG program, including for their small and mid-sized clients. So how do we get to that level of results and the momentum? Jeff mentioned this briefly in terms of the up-down chart. Good care up, bad care down. This is a different way of looking at it, and I'll just focus on sort of the two ends of the spectrum. Ultimately, there's ways to reduce costs, there's ways to change various attributes of how we manage healthcare, but the only way to do it sustainably is to move how that actual care is consumed. The 3 C's, changing care consumption. And so what you see here in terms of the top performer compared to what typically happens on a fragmented, uncoordinated, scattered, broad PPO type solution is double the amount of spend on primary care. Actually looking at that as good spend, looking at it as an investment, not an expense, and seeing that that drives dollar for dollar reduction in other types of care that are really important, as long as it's appropriate and not overused. And we're going to hear briefly from Lisa and our physician colleagues about the power of primary care and how that is the bedrock of the BHCG High Performance Program. Deeper than just more spend on primary care is the right spend on primary care. So one of the hallmark insights of the physician value study is that if all of the care in the community were shepherded by the top performing primary care teams, that would lead to a 40% reduction in cost. Now, shepherding all of the care through those clinicians is hard to do because access is always a challenge, but what we're proud to be able to say today is that of the care going through this program, 20 months in, 94% of it goes through those clinicians that were rated as top performing by the physician value study sponsored by the Business Healthcare Group. And the cost differences are staggering when you look at the high-performing group versus everybody else. So it's not just more money to primary care, it's getting the right types of care into the right types of clinicians, which is what we need to do as a society if we actually want medical school graduates and future generations embracing primary care as where they can actually make a livelihood in medicine. Again, where you're voting with your dollars is driving those decisions, and you're doing the right things here in Eastern Wisconsin. So we shared some of this earlier. What I would point out is the member cost. We showed some big changes in member cost, even with HSA qualified plans. So one of the things that we as an organization have introduced first in this market and have said it's such a good idea, let's do it elsewhere. So I hope you don't mind that we're stealing some of your ideas. But we are now introducing guided high-performance health savings account qualified plans in other places. We started that work here in Wisconsin, even with a high deductible, even with a deductible that meets the requirements to be health savings account qualified, 21% reduction in member out-of-pocket cost. So that's the affordability imperative that's being driven by the work that you've done. Jeff mentioned this client, that consultant in the room. Thank you, John, for your support. So this is a client that already had been on a journey to improve their plan. And this is not a client of 100,000 employees with all kinds of scale and purchasing power. This is a classic middle-of-the-fairway employer that represents this business community, had been on an independent TPA, had already looked at pharmacy strategies, and 2 years in has seen costs go down year over year. Here's what I like to say when I hear those stories. There will be a year in which this organization's costs will go up. People get sick. People need care. That's why we have the infrastructure that we do. That's why we're proud that even though costs have historically been high in this community, quality has been high as well. But what this savings allows this employer and other employers in this community to do is now be better prepared for that rainy day when inevitably there will be a high cost event. It's that type of forward thinking that again is being led here in southeastern Wisconsin. Now, I won't read all of these quotes, but it's been famously said that all you have to do is follow the money if you want to know what's going on in healthcare. Well, if you ask the typical employee, their family, the typical member on a plan, pretty quickly, follow the money. What employees are looking for is affordability, predictability, and simplicity. And we, all of us who've worked in this industry, whether you're a purchaser, a provider, a vendor, all of us have made the error of creating incredible complexity and then buying solutions with the hope that that would somehow remove the complexity, whether it's a navigator, a data tool. And what you're seeing with some of these quotes are real-life people basically saying, now that I am being organized through an experience where I know that the care is going to be of high quality because the data defines it, and that there's a primary care team looking out for me, as long as I follow those two simple rules, I can afford my care again. And that's the key piece that we hear over and over, that what employees are looking for, whether it's through this program or any other program, keep it simple and let me not be anxious about how I might have to pay a bill. So before we close out here, I think you're going to hear a lot of other anecdotes today from the clinical side, where I'm so proud to have an opportunity to hear from Wendell Potter, someone I've been following for a long time. But the other crisis in this country beyond affordability is access. And there's a lot of reasons for that, and I'm sure we'll talk about it a little bit on the panel that we have coming up. But one of the things that we've done, again, in partnership with you, is the ability to integrate digital and other modalities into creating access. And the most fascinating part of what we've seen through this is we can often stereotype that there's a certain type of person that's going to use a virtual care type solution. And maybe that's a young person, maybe it's a millennial, maybe it's someone who's staring at their phone all day. Well, the reality is what we're actually finding is some pretty complex situations that want their care managed in a different way. And so this is an example of a Wisconsin employee who had a high fever. It came off of oral surgery, assumed that it was a complication from oral surgery. Actually, it turned out to be an undiagnosed tick-borne illness. Not only was that diagnosed virtually, but the care was coordinated in such a way that all of the relevant inputs were brought together by consulting with the oral surgeon and other members of the clinical team. It speaks to where we can take this for the future. We are and should feel privileged that we live in a country that's constantly trying to push the envelope on innovation. There will be high-cost drugs. There will be new technologies. There will be things that will continue to put pressure on cost. But as long as we keep thinking about how we drive towards quality and access, we can actually do that at a price that we can afford. So the bottom line is, it is our privilege to be a partner with you in this endeavor. I know we're just getting started. There's a lot of work to do, but congratulations on the last 20 years and look forward to a great next 20. Thank you.
Good afternoon. My name is Lisa Mrozinski. I am the head of Total Rewards at Baird. So if anybody, hopefully everybody knows who Baird is in this room, but we are a financial services company headquartered here in Wisconsin, although we've grown quite a bit in the last 20 years since I've been at Baird and have been a part of the business healthcare group. I'm convinced Jeff asked me to moderate this panel so he didn't have to pay somebody to do this, because I'm setting expectations right now. I'm an amateur, so little grace would be very much welcome. I just wanted to say just a few words before I get into our distinguished panel here, but you know, our prior CEO, Paul Purcell, who was one of the founding members, you know, he was a visionary himself related to healthcare. He didn't even live in the state of Wisconsin, but he was very committed to this organization. And he always talked about how, you know, we needed this organization to continue to do business in the state of Wisconsin. If this organization had not come along, I'm not sure Baird would have been able to continue to do that. So incredibly grateful to him. We rely on the BHCG as part of our healthcare strategy, and that centers around a little bit what Ashok just talked about, you know, an investment in our people versus an expense. And that also centers around accessibility, affordability, and well-being. And I think that's what we're all trying to do as employers in order to show that we care for our associates and employees. So thank you all for having me be part of this be the moderator for this panel. I have a quick introduction. As I said, I'm an amateur, so I have to read my prepared remarks. But then we're going to go and ask some questions, and please feel free to think of your questions as we're kind of talking through this. But you know, helping to drive positive change in the healthcare marketplace has really been something that has been a key tenet for BHCG. And one area of focus has been the support of the advanced primary care model. So our BHCG initiatives have strongly endorsed the value between having effective primary care relationships between patients and primary care teams. Not necessarily the employer, the patient and the primary care team is what we're committed to. And then we went further in designing the high-performance solution, you know, to sit on top of that high-performance kind of chassis, providing employer health plan benefit alignment rather than lip service. So we're really committed to this, and the idea that having a clinical guide, someone who is knowledgeable and connected to the patient, will result in better clinical outcomes for that patient as well as lower costs for the employer. We believe the effort is succeeding as the BHCG. We also believe that it is shared interests of the employer community, so it not only impacts our individual organizations, but impacts our community as a whole. Families are impacted. Healthcare provider community is also impacted to help us execute on this model. We also believe in the effective use of data and metrics to ensure accountability, and that also includes employers' strong commitment to this model. So today, we have this distinguished panel of guests and clinical leaders to discuss this important topic about primary care, and really to explore how this continues to develop in the future and how we continue to optimize this model for the care of our employees and our community. So I'm going to have each panelist introduce themselves, and if you could just give kind of a quick introduction about who you are and how your organization or what the emphasis or the impact of this provision of primary care is related to your organization.
Hi there, I'm Patty Golden. I'm the Chief Medical Officer for Ascension with the medical group. I am a family practitioner by background. I've been practicing for over 20 years in the Milwaukee area. First, I want to say thank you to all of you who have really spearheaded that drive for primary care, being at the center of a patient's experience. For me, as a family practitioner, it is the most humbling and rewarding job I could ever ask for. To have a patient, their family, trust me to be at the helm of their healthcare journey is again, it's so humbling to be part of that with them. And so for you guys to invest in creating a stronger primary care base is just an honor to be amongst all of you.
Good afternoon. I'm Paul Pritchard, Vice President and Chief of Quality from Prevea Health, which is located primarily in eastern Wisconsin and northeastern Wisconsin. I used to say Green Bay, but the team's struggling a little bit this year, so that source of pride has gone out the window. I'm an internist by training. I still have a small practice in addition to my administrative duties. That practice includes just regular people from all walks of life and a cystic fibrosis population I take care of. So I cut my teeth a lot on population health and things of that nature from that group of individuals. And I couldn't have said it better in terms of the primary care emphasis of BHCG. One of the things I've noticed after I got into administration is one of the first things I did, because my panel got a little smaller. Patients knew I wasn't going to be as available as much as I was before. So the ones that stuck with me actually kind of liked me, which was shocking to begin with. But, you know, I increased my visit times because I don't have as many people. I can sit around and talk to them a little bit more. My enjoyment in my practice went up tremendously after I started being able to get to know some of these people. I mean, in the past, and I feel for my partners that are still kind of in the grind, you know, you had time frames, you had to get through things. Now I can sit back and ask them, what are your goals? What are your ambitions? What do you want at end of life care? What are the things that scare you? So as a primary care doc, that's what I went into it for. And like a lot of us, I got lost in some of the shuffle of corporate medicine and things of that nature. So the emphasis of BHCG, putting it back on the primary care docs, is, for me, very rewarding and very important.
Thanks, Paul. Mark Lotus. I'm an internist as well as a pediatrician. Been with Frederick Medical College of Wisconsin for a better part of 20 years. Paul and I go back to residency, so we were residency mates back in the day. Don't ask us when. So nice to, yeah, nice to be on the stage with you, Paul. First, I want to thank the business group, the business healthcare group, for entrusting the lives of your family members and yourselves to us for all these years. I think that trickles down to all your employees that, view our health system and the services we provide as a front door for primary care as well as for high-end specialty care in the region. We could not provide the services we provide today or had the growth that we've had if it were not for the partnership and the trust that you've had in us and the services we provide. For about 15 years before I was in my population health role for the enterprise, I was growing the primary care base for Frederick Medical College throughout the region. When I started, we only had 2 or 3 clinics right around the main academic campus, and now we've got buildings, kind of throughout the region. The vision for this was that we really fundamentally wanted to be a force in driving health and wellness amongst our communities. And we knew the only way to really do that was to have an accessible front door. What we've seen over the last few years, though, is that, when I went into primary care and that fee-for-service model was all around kind of office visits and managing patients during those episodes. But increasingly, our focus on population-based health has really taken us away from that synchronous environment to a more asynchronous environment where we're trying to have a real understanding for which of our patients are at highest risk for disease, which of our patients may not have had their vaccinations done or their preventative screenings done and all the rest. And then layering on a whole nother layer of support and outreach. And that takes a huge team, right? It goes beyond just a single primary care physician with a single patient. It goes to how you layer on medical assistants and nurses and pharmacists and social workers and behavioral health specialists. And so one of our big focuses on the primary care base is how we build those teams, how we build central processes to be able to engage patients and the populations, how we understand who's at highest risk and provide a little bit more service, a little bit more attention, and trying to drive patients to the best possible health we can. So great to be here with you today.
Hi, Wayne Jenkins. I'm the Chief Medical Officer for Centivo. I started out a very long way from primary care as a radiation oncologist, worked for MD Anderson, a large cancer center, but I became very interested in seeing a lot of patients whose health care was unaffordable. And so went back to school, did a Master of Public Health, and got very interested in how we could look at making care more affordable. So I was in a Chief Medical Officer role in a health system in Florida, and then at Vanderbilt in Nashville, but really saying, how can we connect this to primary care? How do we create what you hear about these ACO models, clinically integrated networks? And so early into those advanced primary care models of how do we coordinate care, make it more affordable. But the thing that I started seeing is there was a missing piece. We would create all of these programs, and then no one would pay for it. And so when I met Ashok very early when he had this idea of starting this company, I said, okay, that's a really good idea. I want to go work on that. Can we get the employers and payers involved so we can advance this work we're doing? And so that was really where I came to this. And so of all the places we've been doing it in the country, this is as successful as it gets. And a lot of that is sort of the partnership. You really had good care set up in this area. And now it's how, as you as employers, advance that, make it affordable for people, have payment reform that can push these forward. So it's really been gratifying to work in this market and with these partners.
Thank you all. That was wonderful and very much aligned, I think, with what BHCG is trying to do too. So I'm going to start with a few questions, and then we'll have any other audience questions if you prefer. But I'm going to start with Dr. Golden. So BHCG's conjecture, supported by the data we have seen, indicates that a strong primary care relationship sits at the heart of effective healthcare. So having that medical home, as we've called it, where people actually know their physician, right? They see him in the grocery store and they're like, hi, instead of walking the other way, right? That's kind of what we're after. I think we believe Ascension is in agreement with that proposition, and you can dispute that if you choose. And we've heard from the provider community that there are certain elements necessary for success of that primary care model. What do you believe those elements are?
Yeah, we do agree.
Okay, good.
So we will not dispute that. And I think each of the panelists have touched a little bit on already what is really critical when we're looking at the best care possible for our patients. And it comes down to the relationship. It comes down to the relationship that you build with the physician and the care team providing the care to our patients. And with that, automatically, as you develop those relationships, you develop trust. And that trust is then what helps deliver the right care for the patient. And I loved how Paul talked about, just being able to spend that little extra time and listen to your patients. Each time you encounter them, you learn more about them, and you learn more about their history, their beliefs, their needs. And so as we're developing those relationships, I know that we're going to be able to offer the right type of care for our patient. But the other thing that BHCG has done is that they've also incentivized their employees to come and see a primary care specialist. So, one of the things that I think we all struggle with is, there's a lot of access to get in for healthcare, whether it's through the doors of the emergency department, coming through the urgent cares. Yes, those are opportunities for patients, but a lot of times it's not the right place to go at that time. And so, again, when you have those relationships, that's where they know the first thing they're going to want to call Paul. They're going to want to call their primary care physician and ask them, what is the right thing for me to do? And, with that comes the responsibility of us as health systems that we have back towards BHCG is that we're going to put high quality providers in those positions. And so what that means is not only are they going to be making the right decisions, but they're also going to be driving the health outcomes for your employees. We've committed to making sure that we're providing everyone with all of the metrics. We've sat with the teams and come up with what are the goals, what are the outcomes, what are the best practices, and what are the quality metrics that are important to your associates and your employees. And those are the things that we're going to be constantly having conversations about. We're providing the data so that you guys know that we're doing what we've committed to say that we're doing, and also that we're all uniformly working together. So with that also comes our commitment to providing compassionate but very quick availability to our primary care physicians. So,
Great, thank
that's...
you. Dr. Lotus, primary care-centric models have sometimes been criticized as a subterfuge for simply maximizing revenue and getting people in the system, and really not addressing the patient and what their needs are. What would you have to say to those detractors that might have that opinion?
Well, I do think the old model of healthcare may have promoted some of this, and as we know, historically, payments to primary care has been significantly lower on average than what payments are for disease-based care to specialists or procedural-based care to specialists. I think this has put primary care in a position historically that they've been a bit of a loss leader with respect to the groups that they're in or the health systems they're in. And I think that has naturally, over many years, resulted in a look at what is the downstream impact? How can we justify that cost? What is that downstream impact on a fee-for-service basis? I think it's exactly the wrong, view. I think our contemporary view of primary care is one that is going to promote the health and wellness of individuals, that's going to result in greater preventative care and early detection of disease. It should come to no surprise that, if you have your mammograms regularly, that women that do that on a regular basis are likely to be, if they are diagnosed at an earlier stage of the disease and are more likely to cure at a lower cost and a healthier lifespan. And you can say the same things for preventative immunizations and good care of chronic disease. So that's all in the wheelhouse of primary care. I am a proponent of really looking to a future model where at least that primary care base could be paid on a per member per month or on a more of a capitated or fixed basis for the work that they're doing. It would allow us to take care of a lot more patients. Our providers in our system are spending still the majority of their time in office-based visits or virtual visits. It's really that interaction and that transaction and the documentation and the billing that gets them paid. In more progressive models where you've got more integrated health systems on that more fixed payments to primary care, they're spending a lot more time on things like texts with their patients, emails with their patients, contacts, and the statistics are those health systems are able to have each primary care physician have a much larger panel of patients they're managing as well. So there's an efficiency there, especially as we're in primary care shortages. So in short, I think, that philosophy that you mentioned, I think certainly I have not been immune to hearing that over my career, but I think it's exactly the wrong philosophy. And what we should be doing and what the focus is, I think, of every single one of the physicians in our group is to take the very best care for each of their patients, get them the best health outcomes, and prevent a lot of that downstream and subsequent utilization that would otherwise occur.
Yeah, and I'm sure we'll continue to have more discussions about your recommendations, or your thoughts on that. Dr. Pritchard, as part of the BHCG high performance model, we have integrated data elements that ask our healthcare providers to do some more difficult things. The underlying data from the physician value study said that there is a substantial variation in the quality and cost effectiveness of physicians in Wisconsin. And we as BHCG employers kind of made that tough decision to say until the underperforming PCPs can raise their performance to serve as the patient's clinical guide, that they would not, be in the network. We know this was a difficult ask, but you also know it's an important element to drive change for us within the Wisconsin healthcare landscape. What are your thoughts and reactions to that approach?
Well, the first reaction is always denial. You deny the results. But once you get beyond that, I think many physicians, especially in our group, are responsive to data. None of us went to school to be the worst doctor. We don't go to work on a daily basis to provide poor care. We took an oath to do the exact opposite. But, I believe, my personal opinion is a lot of what happens in our organization, I don't know about other organizations, is you've got people that trained in the 80s, you've got people that trained in the 90s, you've got people that trained in the early 2000s at different places. They were all taught different ways to do things. They were all taught different methodologies, different importance on certain things. The one thing that was consistent, though, is that patient sitting across the table from you is your responsibility. Don't mess it up. And so when you get a provider into a situation, a clinical situation, they're going to fall back on their training. And so unless you're showing them accurate, timely, actionable data that says, hey, you're not doing as well as some of your other peers, their likelihood of changing is probably not going to be very high. You have to be able to show them this is what's happening, this is how we think we can do better as an organization. And we've had a couple of examples of that in our own group so far. We looked at a surgical specialty. We evaluated the three of them. There was three of them. And there was a cost difference for us of $1,300 to provide a particular service with no difference in the outcome. And you go back and you start talking to them about why do you do it this way? Why do you do it this way? And orthopedic surgery is a perfect example because they all have different vendors that they've used over the years. Why do you use this Stryker product versus something else? Because that's the way I was taught. So you have to really kind of go back and show them the data, not only from quality but also from cost perspectives. And sometimes that's a difficult ask unless you have, like I said, the data sitting in front of you. So that's where the BHCG information is helpful for me to go back to my partners and say, hey, we've got a problem here. We've got to be able to adjust, be able to provide a valuable service to the people that we're providing care for. And by value, I mean high quality, low cost. And that's not always easy. I mean, we have, I'm sure you guys got examples of surgeons that still want you to do a battery of lab tests prior to a procedure on a 28-year-old who's healthy. And that's non-value added. Anything that's non-value added doesn't improve your outcome, is inefficient, and is an expense for either us or for you. And we've got to get rid of that.
Yeah, and we as employers want to be able to confidently say these are high-performing physicians, so thank you.
We're highly competitive, and
Yeah,
so
that
yeah, it
works,
shows the
right?
data, and yes.
Competition works, that's great, yeah. Dr. Jenkins, you are now the Chief Medical Officer of a health plan, but for a long time we're on the dark side, right? What insights does your past experience bring you to this role at Centivo?
So I alluded to that, just seeing that tremendous cost pressure on patients. That was probably what it, initially what it was. And then going back to how do employers engage, because that's how so much of the healthcare is paid for. That was a big part of it. But really, when I always looked at it on the delivery side, as working with our primary care physicians, it was that, access to care and engagement. And so, free primary care and really getting people in. I was really, one of the things that's really worked well in this area is, I think Jeff showed the primary care visits going up, but in one of those slides it showed it was those wellness visits went well up. And so I think that engagement access without the financial impediments. And so when you see those wellness visits going up, the group here has done a really good job of engaging people early on. And where that's important is if you know your primary care team, your first visit isn't to the ER. Or if you engage people, you do that screening colonoscopy and you find that precancerous lesion. And that leads to all the good quality and cost results. So I would say my other side was looking at the payment side from a distance and saying, okay, here's the things that we need on this side. So when I would go meet with, say, primary care physicians or health system partners, I was always coming at like, hey, I know what it's like on your side. Here's how we need to do things differently, when we're on the payment side.
Okay, great, thank you. So for any of the panelists, this isn't a new concept, focusing on primary care. I think we've seen some of the results that, Centivo is producing related to that. So one simple question for all of you, why aren't more people doing this? Like, why aren't we all doing it?
Why aren't more people in the country doing it?
Yeah.
Now that one I
Yeah.
have an opinion about.
Oh, okay, great.
I mean, it's really remarkable, and I've talked. I mean, because so when I was in Orlando, we did this direct deal with Disney. And Disney had 100,000 people, and I thought everyone was going to rush in and say, okay, now we'll do that, and they didn't. So I think maybe that word courage at the beginning is a lot of employers are just like, we don't really want to do this because somebody's going to complain somewhere. And so as I go around the country, where we're doing this in different markets, like, oh, we don't really want to rock the boat. And I'm like, well, look at how much, look at the problems your employers are having. So I think a lot of health systems, I mean, not all of them, but I mean, around the country, there's a lot that are wanting to design this way, but there's just this reticence to push it forward because of the fear of change.
Because they don't want to deal with the complaints.
Go ahead.
Yeah, so what's really interesting is even 20 months ago, I remember sitting down, my brother works for an organization who BHCG is supporting, and the initial conversation that I had with him was about, well, I feel like I'm giving up my choice. Like I want to have choices where I can go, and so the conversation I ended up having with him is I said, your employer is committed to finding you the best care possible. And again, we can talk about expenses, but it really comes down to you guys have made a commitment to making sure that your outcome is the best there possibly is. And so that choice really isn't as important as I think people think it is. And, again, when we're talking about show us the data, when you show patients, like, you are going to the high quality, we are going to do it in a cost-effective way. And I loved the slide that showed the cost to the patient is significantly lower. That's huge.
Yeah.
I think you really have to, when you ask that question, I'm kind of wondering which perspective are you looking at it from? If you're looking at it from the employee or the employer, why don't you do more of this? It's change, and you hit the nail on the head. I have a lot of patients that'll be like, well, I don't want to switch my provider that I've had for 20 years. Even if you show them a report that they may not be the greatest, they still believe in that provider because they have a relationship. If you look at it from the healthcare perspective, it's where the incentives are. I mean, I think it was Deming that said something along, your system will get what it's perfectly designed for the results it gets. We've been for so long, and Mark said this, been paid based off of volume, paid off of utilization, paid off of, those types of things. So for us to put the infrastructure in now, we have to be incentivized. We have to be involved in things like this. They're going to say, no, we need to switch the curve. We need to be able to put a different emphasis on how our systems get reimbursed. You were kind of hitting on that. So.
Yeah, I mean, I think historically too, just to build on that, in the 1980s, we saw the big rush to HMOs, right? And narrower networks and, primary care as gatekeeper model, right? And I think the pendulum swinging away from that in the 90s and the early 2000s to more indemnity of PPO plans really took us away from that. I think in some respect that de-emphasized maybe the importance of primary care. I don't know that primary care physicians necessarily like to be in gatekeeper model for every single, healthcare need that patient had in terms of, authorizing, the service or not. But that's the position they were, and then they were no longer in that. And I think it moved patients away a little bit from that primary care base and more to the specialty care. I do think the brilliance of this is really emphasizing in plan design the importance of primary care and getting people into that primary care base. We're not a huge fan, honestly, of the tiering. We think there's too little primary care physicians out there to do that. We think that there is a lot of selection bias that's taking place amongst our providers. If I got someone working in the inner city clinic versus in the suburb, quite frankly, I can tell you which one's going to have the better quality numbers, okay? And there's a lot of other social determinants and other factors outside the delivery of health care that's driving that. But that said, I think, like I said, I think the brilliance of this is getting people into primary care, stressing that relationship, assuring that that's happening, trying to get them in with someone they can trust, and then making sure that all that preventative care and general care is taking place. There's a different bar for our specialists in terms of the extent of a workup they do when someone comes in with a complaint. And that's because the sense is that, we in primary care have had a swing at that ball before already. That the common things we've treated, we've diagnosed the things that we can do, and now there's something more complex with something more going on that we're sending it to the specialist. If you just send everyone directly to the specialist, I can tell you they get a bigger workup, okay, in my experience as a primary care physician. So I think there's great value to that primary care stop as the first stop, and we're completely in line with BHCG and Centivo in, making that a priority.
So I wanted to comment on the gatekeeper comment. So one of the things we get asked is this like the 90s in a gatekeeper model? And we really want to emphasize how it's not, because I used to see a lot of primary care physicians in the 90s, and it's like, who wants to be a gatekeeper denying people things they need? That was dissatisfying all the way around. So if you look at this, as you said, the plan design, and so we'll go into markets and talk to primary care doctors like, oh, wait a minute, I've got to do referrals. It's like, no, all the referrals that you do are approved. Now, if someone needs, say, a complicated spine surgery, maybe that goes through a pre-authorization, but all the primary care referrals are approved. There's no gatekeeper aspect to it. And it's really when you start, then you talk to the primary care, it's like, oh, okay, now people come back through me and I know what's happening. Or I could say, maybe you don't really need that level of care, you need a different level of care. So it's really designed around the primary care team being, the integrator, the quarterback, but not the gatekeeper. And it really is different now.
Okay, great. So we believe that this primary care model has benefits, many other benefits in addition, just to getting patients great care. This would include things like, when they're really understanding the person and, financial worries and maybe, an abusive relationship or all of those other things that are part of that whole person. Is this, having kind of that approach, asking too much of the physician?
Yeah, I mean, I can jump in first on that one. I think if it was just that physician, that primary care physician and their patients, yes, it is too much. And we're seeing, a degree of burnout. I'll be frank. You see it in the literature around that primary care base. Providers leaving primary care. We've certainly had many of our physicians cut back their time because of the stress involved in in taking on a longitudinal responsibility for a large panel of patients. So I do think it's a little too much, but we also know that only 20% of health outcomes in communities is related to the delivery of health care. So while, we hold ourselves in esteem for the fact that we can provide great care to our patients and that we have these great resources that we can bring to bear, only 20% of our community's health outcomes is due to health care. The rest of it is due to other social factors, environmental factors, economic factors, housing, transportation, all these social drivers of health that we talk about. So our ability to really affect those, I think, is that next step in our evolution of really driving health. From healthcare delivery and a healthcare system standpoint, we feel we have a fundamental responsibility to that. So we put in a whole layer of 20 ambulatory social workers to support our network of primary care. We've put in care coordinators that can help navigate patients to solutions that will, community-based solutions in their own communities that can help solve some of those problems. And I know the other health systems on this, panel are doing much of the same work. We do need, though, that investment, longitudinally. We need to make that investment in those solutions. And even more important reason why that funding for that primary care piece, which is inclusive in our system of all these other, services that we're trying to provide, is recognizing that investment we're making and the impact that we're trying to have on total spend. At the end of the day, if we do that well, it will result in lower and lower costs of care for all of our populations that we treat.
And I think too that, just to piggyback on, that was so well put, thank you. Us also partnering with the employers. There are things like, Janice, when I was talking to you last night, I was so excited about the things that you guys are creating for your associates. The in-house wellness that we can partner as health systems. Everything you are doing and you're providing to your associates, whether it be mental health, well-being, assisting with the preventative screening, all of that just contributes. And so anything that we can do as a health system partnering with the employers is going to be critical because, we can't do everything sometimes.
And that's the value of the partnership with the systems and the BHCG.
Just very briefly, because I can't add much to what these guys did, just an experience I've had, when I've looked at my cystic fibrosis patients, I get very lucky because we have a team already established for that group of patients. But one of the things I think we fail at is behavioral health kinds of things and building that aspect to our primary care base. So when you asked, the original question was, can this all be expected to be primary care? No. I mean, you have to have so many more elements in place in order for this to be successful. When my CF patients fail, it's not because we haven't given them medications, it's because they're depressed and they stop taking their medications. So we have to build that whole infrastructure. It can't just be the primary care doc, and you have to have a different emphasis than on just utilization and fee-for-service kinds of things.
Great. I have one more question, and then we'll open it up. So there's a lot of talk about really changing the payment models. If you were in charge, where would you stop or reduce payments? Where would you cut if you had to?
I'd cut insurance company profits, but that's probably,
Probably
I'm
that's
not
a
sure
perfect
how
way
to
say
answer this
it.
question.
I can tell you where to invest, you know, continue investing in the primary care, but, yeah.
Yeah, you know, I think where you don't, where you want to continue to provide services and that most fundamental preventative and basic care, right? I mean, that ultimately, you know, having that network of care throughout our communities is essential. And it's essential to the health and wellness of, you know, your employee base and being able to run a company. If you don't have a healthy company, you're not going to be very successful. I will say that the growth that we've seen in some of the pharmaceutical and specialty drug spend has been astronomical. And I do think that, you know, some controls need to come into place in that sector if we're going to be able to afford the delivery of healthcare moving forward. So I think, you know, this is a bit of a moving bogey because every few years you see one sector of healthcare spend, you know, moving in a direction and a trend that you know is not going to be sustainable if it continues at that. And, you know, I sit on our own benefits committee for our own, you know, self-insured employees of the health system. And, you know, we're facing the same kind of things that you all are seeing and, you know, from a business perspective. I think the question is how do we, every dollar we spend, how do we spend it in a way that gives the greatest value? And we know that there's not an infinite amount. And so putting those constraints in some of those areas where you might see a trend going, you know, that is unsustainable, I think it's our responsibility, you know, as leaders to, you know, and as physician, you know, as physicians, to help to be part of the solution to get those dollars spent in the most important and impactful ways as possible.
I wanted to refine my answer, because I was picking on the insurance company, but, you know, I think when I look at it, our healthcare system, first of all, this isn't a system, this is just a joke. We have way too many stakeholders that have other agendas than patient care involved. So you can go down the line, whether it's insurance company profits or it's pharmaceutical companies that profit off of people being sick, or hospitals wanting heads and beds, or physicians not following evidence-based medicine or providing low-value care. The answer, I guess, to me is you have to work on all those things. It can't just be cut the insurance company profits. That's somebody else will figure out some way around that. But as a physician, what do I have that I can change? What I can change at my organization is looking at data that we get and saying, no, if this doesn't improve the outcome, it's inefficient, it's lost somebody money. And we can't continue to do that. Not when you have 20% of our GDP being spent towards healthcare and $12,000 per patient per year on healthcare. It cannot continue that way. So as a healthcare provider, we have to look in the mirror a little bit and say, what can we do? Those other things we have to continue to work on too.
Yep, there's no one solution, right? So I think we have a microphone set up right in the middle here. So does anyone have a question that they would like to stump our panel with? No questions? Come on. Diane, of course, will ask a question.
Well, first of all, I don't want this to sound gloom and doom, but one of the things that's been on my list to do is hospice. And so I am now doing hospice nursing to take it off my bucket list. And it's very rewarding, but it also has brought to my attention both from a professional standpoint and a personal, family members, et cetera, that there's not enough focus when people are healthy and not dealing with a major issue to talk about end of life. And I wondered if you could address what your organizations are doing to, talk to people when they're healthy and to find out what their real wants are. Because once they're sick, they really can't do that anymore. Thank you.
Yeah, and it's also a really hard time to start the conversations with family is during that time. And so, yeah, that has been a huge conversation that we've been having in the primary care world. And it's about, like we were talking about, when you start developing those relationships and you're spending that time and you're getting to know your patient, that's the perfect time to start having those conversations. And, we're starting to have the end of life conversations and putting them into the charts, and then we're updating them. And so, do I think it's ingrained? No. Do I think that there's a lot of comfort with our primary care clinicians having those conversations? We're working on it, but my colleagues might have some additional conversations. But you're right, that it's incredibly critical to start having those earlier.
Right, and we put, our patients through a lot at the end of life, right? We put our family members many times, if any of you have lost a family member in the past, may have seen them go through a lot at the end of life. We spend, about 40% of the healthcare spend, is in those last few months of life. And sometimes we aren't, I think, as physicians, as attuned to letting go, particularly as we get into certain episodes of care. We still see, for example, some of our patients that die with cancer and advanced cancer may pass in hospice within a week of just gotten a recent chemotherapy dose, for example, which really should not happen. I mean, that's pretty far toward the end of life when you're giving that chemotherapy that late, for example. So we have a lot that we can do in this space. I think what we're doing organizationally, because I think there's the piece of the goals of care and the discussions when someone has a serious illness. But where you really need to go, in addition to that, is hopefully get upstream from that to when they're healthy. And we've looked at our patients that are 65 and older and said, what % of our 65 and older, just starting there, have an advanced directive on file, advanced care plan on file? And it is only around 35 to 40% of our population today. Now, we think a few more than that have, and we just don't have that loaded into the record. But we have really set a goal to turn that, to trying to have 90%. We're integrating it into our annual care visits with the patients. We are pushing patients to our social work team to help them with that. And then we have a unique digital tool that we're using that allows the patient, because this is a real key, the patient to choose their agents. And then a list of questions about what they would want. And the patient can then take their time and go through scenario planning and thinking about what they would want in various situations. Would I want the ventilator? Would I want feeding tube? What would I want if there wasn't a hope of me surviving in a meaningful way and cognitively intact? And what would I want my family members to make a decision on? Write those down and then share it with the agent. Then the agent can ask questions back. And then we can take that document and put it into our record along with the advanced care plan. So now we understand kind of what that discussion was. And then if that happens, now you have an agent and a family that can all see those documents too, understand them, and hopefully be aligned. Because we do get a lot of, when the agent comes in and the rest of the family members are all around from out of town and elsewhere, sometimes we don't get complete concordance, at that moment too. So we think that doing, kind of approaching in this way is not only going to give us, one of the goals, which is to have more advanced care plans on file, but to have quality plans that have that additional knowledge sitting behind them.
All right.
So can I just add
Oh,
something?
go ahead.
I'm sorry. So first of all, thank you very much for bringing that up, because that was an element we didn't talk about that we really should have. I serve on the Unity Hospice up in Green Bay, and you're right, it's one of the more rewarding things I've ever done in my career, and I think in terms of the art of medicine, It's what we really need to be doing more often. When this really came to be an issue for me was about 15 years ago. I had a 96-year-old patient who I got to know very well with his family. He was admitted to the hospital 4 times in a 6-month period of time. And when he passed away, his family looked at me and, we were in good terms. And they said, well, that was so sudden. And I kind of took a step back because like Mark said, I think as providers, sometimes we have tunnel vision. We see disease. We want to stamp out disease. If somebody dies, we failed. So you don't realize that sometimes, and I think it's, like Patty said, it's a very difficult conversation to come up to and be able to say to a family member or to a patient, hey, we're going to die. How do you want to do it? And so we've also started to implement a lot of the same structural things that you did, but it's something, again, I've realized after I got in administration and I had more time to spend with my patients that I would realize I wasn't doing very well in the past. And I'm still not great at it, but hopefully we're getting better.
Well, thank you. It's been my pleasure to be moderator of such an esteemed panel, and I'd like everybody to thank our physician panel for their conversation. Thank you.
Hi, good afternoon. I'm Janet Lucas-Taylor from Northwestern Mutual, and it is my distinct honor to introduce our keynote speaker this afternoon, Wendell Potter. This gentleman is so accomplished, I can't do this without his bio in my hands, so I don't miss anything. Wendell is an advocate for American health insurance payment reform, New York Times best-selling author, and a former health insurance industry's communication director. After really seeing firsthand how strategic PR and lobbying is used unfairly to tilt the scales towards corporate interests over the people's interests, he left his corporate career to advocate for meaningful change in healthcare and healthcare reform. Wendell has testified before Congress, spoken at more than 200 public forums, and authored 2 books. He is currently the president of 2 not-for-profit organizations, the Business Leaders for Healthcare Transformation and the Centers for Health and Democracy, which convenes the Lower Out-of-Pocket Costs Now Coalition. He also publishes the newsletter Healthcare Uncovered, and for those of you who are not subscribers, I highly recommend it. It's fantastic. So please, will you join me in welcoming Wendell Potter. Thank you. Such a pleasure.
My pleasure. Thank you. I'd like for you all to do some dreaming with me this afternoon. We often hear that the United States of America not only is the richest country on the planet, but also the richest country in all of recorded history. We also hear that we have some of the best doctors and hospitals in the world, and many of them are, of course, right here in Wisconsin. So now let's dream. Let's imagine what our country would be like if 25 million of us were not uninsured. 60 million of us were not functionally uninsured because of high deductibles and other cost-sharing obligations. 100 million of us were not saddled with medical debt. And imagine that our doctors didn't have the highest suicide rate of any profession, that our neighbors were not dying of diseases of despair, and that we lived as long as folks do in Costa Rica and Cuba. We don't. And imagine that we lived in a country where we didn't have to spend $4.5 trillion on health care because about 30% of that is going to administrative functions and profits. Or just last year, speaking of profits, the 7 largest or the 7 for-profit health insurance companies took in $1.25 trillion in revenues and made $60 billion in profits, and these are the companies that comprise what is often referred to as BUCA, plus a couple more, Centeva and Molina, that are almost pure play public insurance companies that play in Medicare and Medicare Advantage and Medicaid. And now imagine that not a single one of us would have to resort to getting care in barns and animal stalls. Now, I mentioned that last one because you might not know that getting care in animal stalls is a reality for many people in this country. I didn't know it either until I took a trip back home to Tennessee a few years ago to go see my folks. At the time, I was vice president and chief spokesman for Cigna, and looking back on that time, I think a more appropriate title for me would have been chief propagandist. This was in 2007, when a growing number of lawmakers in Washington were saying they were going to try once again to reform the U.S. healthcare system. This was 13 years after I had helped send the Clinton healthcare reform plan down in flames. I was already deep into strategic planning with my peers in the industry to kill whatever Washington came up with if we didn't like it. When I got to Kingsport, Tennessee, I noticed a story in the local newspaper about something called a healthcare expedition that was being held at the Virginia-Kentucky Fairground in Wise County, Virginia, which is about 50 miles north of where I grew up. The story said that people were going to be driving from hundreds of miles away to get care that was being provided free by doctors and dentists and nurses who were volunteering their time over a 3-day weekend in late July. According to the newspaper, this was the 9th year that an outfit called Remote Area Medical had held this pop-up clinic in the heart of the Southern Appalachians. But I'd never heard of it. I was intrigued because the paper said that a lot of those folks, as you can imagine, were uninsured. It just so happened that I was writing an industry white paper at that time to make lawmakers and the public try to get them to believe that the problem of the uninsured was not a big deal. I was able to try to make that argument by slicing and dicing data in certain ways. And I wrote that a lot of the nearly 50 million people who were uninsured at that time were that way by choice. They were just shirking their individual responsibility to buy health insurance. What I was leaving out, of course, was that insurers back then routinely refused to sell coverage to millions of Americans because of a pre-existing condition. We referred to those people as uninsurable, and we blackballed about 1 of every 3 people who applied for individual insurance back then. I decided to go check that scene out in Wise County. So I borrowed my dad's old car, and I drove up there. And folks, I've often said that U.S. Highway 23, which meanders through the mountains between Kingsport and Wise, was my road to Damascus. I was not the same person on the drive back home. When I got to the fairgrounds, the parking lot was jam-packed, and I had to park about half a mile away because there were so many cars there. And I noticed as I got close to the fairground gates that a lot of folks had spent the night in their cars because only a limited number of people could get in the fairground at any given day. A lot of them spent the night in their trucks. When I got to the fairground gates, I really couldn't tell what was going on until I walked inside. And when I did, it was as if I'd been hit with a lightning bolt. I saw people who were lined up by the hundreds they were soaking wet because it was raining that day. But they were not about to lose their place in line. And I noticed that a lot of those lines led to barns and animal stalls. Volunteers, before this started, had tried to clean up those animal stalls as much as they could. This is the United States of America I'm talking about. I couldn't believe what I was seeing. And it shook me to the core. And I realized a few things at that time. I realized that I had to take some responsibility for it because as chief propagandist for a big company, my job was to make people believe things that really wasn't true, to obscure very important facts, and to try to achieve my top major job objective, which was to enhance shareholder value. I also realized that the job that I was doing, in many cases, was the exact opposite of what I tried to do in my first career. I wasn't an insurance executive all my life. I started out in the journalism business. I was a newspaper reporter in Tennessee, and then later in Washington. I covered Congress and the White House and the Supreme Court for Scripps Howard newspapers, which sadly is no longer. But I realized that day that during my career as a journalist, I always tried to be honest, straightforward, never to intentionally mislead people, never to leave out, never to obscure important facts. But I realized that's exactly what I was being paid to do, and paid quite well to do, to make lawmakers, the media, the public, again, to believe things that just simply was not true. And I realized, too, that if my parents, who were working class, hadn't scrimped and saved and put enough money in the bank, I probably would have been one of those folks, or could have been. But I was able to go to college and get a good job. But those folks in those long lines could have been people I was related to, people I could have grown up with. But I did make a commitment that day that I would have to find some other way to earn a living. But you know how things go. I went back to the office. I told some of my colleagues what I'd seen. And the next week, I was back flying on the corporate jet with the CEO from Philadelphia on that trip to Connecticut. I knew that the cost of jet fuel alone was about $5,000 for that little trip there. And I was paying more attention. I noticed that it was at lunchtime. We were served lunch by a Cigna employee who was our flight attendant. And we were served on gold-rimmed china, given gold-plated flatware to eat it with. We were sitting on leather seats. And I, for some reason, thought back to what I'd seen just the week before, people getting care in animal stalls. But it would take something else that would make me really walk away from my career. A few months later, one of the jobs of my staff and me was to handle what we referred to as high-profile cases in which people would complain and sometimes get the media's attention, sometimes lawmakers' attention, because they'd been denied something that their doctor said they needed. In this case, Natalie Sarkeesian, a 17-year-old girl in Los Angeles, needed a liver transplant. And the transplant was scheduled, and the family arrived at the hospital waiting for the surgery to begin. But instead, one of the surgeons took the family aside and said, "I'm sorry, we can't go forward because Cigna has not given us clearance." And the family had no idea what the doctor was talking about. They knew that transplants were a covered benefit, but they were told that a Cigna medical director in Pittsburgh had reviewed the request for coverage and had decided, in his opinion, it wasn't medically necessary or medically appropriate for Natalie. Well, the family became a very squeaky wheel, which is what I advise anyone to do if you're in a similar situation. Do your best to raise a stink. They got the media involved in Los Angeles. They got the National Nurses Association involved. They got the Armenian community involved. And it became just a horrible few days for my staff and me because we were constantly fielding questions, calls from reporters there, but eventually all over the world. CNN was covering live a protest that the family had staged was planning to stage in front of our headquarters, our Los Angeles headquarters, actually Glendale headquarters. And I had it on my TV. And I rushed to the CEO's office and said, "Look, this is what's going on." He quickly called the chief medical director and the president of Cigna Healthcare. And within a few minutes, a decision was made to reverse that denial. And part of my job was to try to figure out how to get the word to the family. And I did that. And I reached out to a lawyer I knew in the Glendale office. I could tell as I was watching TV that someone had whispered into Mrs. Sarkeesian's ear the good news that Cigna was going to cover the transplant. And I felt pretty good about myself. You can compartmentalize a lot, and I did that throughout my career. But I wish the story had a happy ending. 5 hours after Cigna agreed to cover the transplant, Natalie passed away because Too much time had passed since the original request was made. She got sicker and just was no longer eligible for that transplant. That was it. I did not have it in me to continue in that job, doing that kind of work. So not long after that, I turned in my notice and I walked out. I was on May the 2nd of 2008, and my last responsibility was to handle the financial communications for the company's first quarter earnings, which was what I had done for many years. My name was in every one of Cigna's earnings releases for 10 years. And again, I also had a big role to play in working with my colleagues in the industry and putting together political and PR campaigns to try to kill any kind of reforms we didn't like. Over the next several months, I started reaching out to healthcare reform advocates in Washington who I knew would be pushing lawmakers to pass a big reform bill. And my plan, my idea, was that I could work behind the scenes to tell them what I had been working on and what the industry was likely to do, what their talking points were going to be, because I'd helped write them. Eventually, though, when it seemed that lawmakers were beginning to lose their nerve, I was told that if I really wanted to make a difference, I should go public with my story, and frankly do it as a whistleblower, which is what I did, albeit with a whole lot of reluctance, because I knew that the lengths that my old industry goes or takes to discredit its critics. But on June the 24th of 2009, I took the plunge into a very deep and unscary unknown. I testified for the first time as a whistleblower before the Senate Commerce Committee. And this is how I introduced myself that day. My name is Wendell Potter, and for 20 years, I worked as a senior executive at health insurance companies, and I saw how they confuse their customers and dump the sick, all so they can satisfy their Wall Street investors. Well, my testimony attracted a lot of media attention. My first interview was with someone I admired for many years, Bill Moyers. After that, I did countless other interviews. Time Magazine, the Washington Post, the New York Times, and a lot of other outlets wrote about me. And I started getting calls from publishers wanting me to write a book, which I did, which Janet mentioned. It was called Deadly Spin. I've actually written 3 other books since then, and hundreds of op-eds that have appeared in media outlets around the world. And I've been extraordinarily blessed to be able to do this work, and frankly, lucky to still be standing here. My second book, by the way, is called Nation on the Take, How Big Money Corrupts Our Democracy and What We Can Do About It. And that is at the heart of the reason why it is so hard to change our healthcare system. In many cases, it's the problem of money in politics. Well, I'm still at it. I lead 2 nonprofit organizations that are focused on healthcare reform, one of which is a business group, and also a coalition of about 70 businesses and organizations that are pushing to hopefully send high deductible plans to the ash heap of history. And by the way, a lot of folks who go every year to a remote area medical clinic have insurance. They just can't use it because of their deductibles or co-payments or their co-insurance obligations. So they go stand in line and wait for care in barns. And now I also publish my own newsletter, Healthcare Uncovered. I do hope you will sign up for it. This morning we published a piece that I wrote while I was waiting to come over here at the Westin. Here's what I wrote. Some of you, I think you've told me you read this. We published it a few hours ago. I'm writing this in my hotel room in Milwaukee, where I'll be speaking to a gathering of local business and community leaders later today about what I think they might want to understand about big insurance. Actually, I scrapped my prepared remarks when I saw the shocking but completely credible investigative reporting by reporters at Stat News. It appeared yesterday. It was about United Healthcare's private Medicare business, which they market and other companies market as Medicare Advantage, and the company's use of AI to deny or severely restrict access to often life-saving care. And today, those reporters, Casey Ross and Bob Herman, are reporting that a class action lawsuit was filed late yesterday against United Healthcare. The lawsuit, which was filed in federal court in Minnesota on behalf of the families of 2 United Health Medicare Advantage enrollees who died, accuses the company of using an algorithm to systematically deny coverage to elderly patients needing rehab and skilled nursing care. Now, I plan to use their reporting, as I wrote here, during my speech, this is what I'm doing right now, to drive home my overarching point that big for-profit insurance companies will do whatever it takes to make Wall Street happy. And in their relentless pursuit of profits, they're putting Americans' lives and their bank accounts at risk. The headline of that stat story was, United Healthcare pushed employees to follow an algorithm to cut off Medicare patients' rehab care. The story, which was meticulously reported, rang very true from both my professional and my personal experience as a former health insurance company executive and as a son of a former United Healthcare Medicare Advantage enrollee. Had I not been able to switch my mother out of her MA plan and into traditional Medicare after she broke her hip, I believe she would have died years earlier. The stat story, along with another blockbuster story that appeared in the New York Times last October, a year ago in October, under the headline, "The Cash Monster Was Insatiable, How Insurers Exploited Medicare for Billions," should be required reading for every member of Congress and anyone who cares about how big insurance companies are sucking trillions of dollars out of employers' and taxpayers' pockets while sending many of our people to early graves. Now, here's the first paragraph of that stat story. The nation's largest health insurance company pressured its medical staff to cut off payments for seriously ill patients in lockstep with a computer algorithm's calculations, denying rehab care for older and disabled Americans as profits soared, a stat investigation has found. A bit further down the story, there's this. Internal documents show that a United Healthcare subsidiary called NaviHealth set a target for 2023 to keep rehab stays of patients in private Medicare plans within 1% of the days projected by the algorithm. Former employees said missing the target for patients under their watch meant exposing themselves to discipline, including possible termination, regardless of whether the additional days were justified under Medicare coverage rules. And then there is this. The stringent performance goals was part of a broader effort to reduce expensive nursing home care for frail patients with privatized Medicare plans, the internal documents show. The strategy was conceived and executed by former top Medicare officials whose policies became a blueprint for United Health to reap hundreds of millions of dollars annually by shredding the government's safety net with payment denials backed by an algorithm. The story quotes by name one former United Health employee who says she was fired for approving coverage for care she felt was justified, but that made her an outlier within her department. You can be certain that Stat's lawyers reviewed every word of this story and made sure that the reporter's findings would hold up to scrutiny. When I was a VP and department head at Cigna, I had to rank the employees under me based on how well they met their annual job objectives. If an employee fell below a line that HR and the C-suite had drawn, I'd have to fire them. There was no wiggle room. It was called forced ranking, and it's really gut-wrenching to have to carry that out. Every employee of the big for-profit health insurance company knows that they have to do their part to help the company achieve profitable growth and enhance shareholder value. You do not need to get a memo that explicitly states that. It is part of the corporate culture and way of doing things. You learn quickly that you are in competition with your coworkers, and you'll do whatever you can to keep from falling below that line. You do not want to be seen as not a team player and not engaged in your work. Reading those reporters' stories brought back the nightmare that my mother found herself in when she needed rehab and skilled nursing care. We learned there was a very short list of facilities in United's network in her area of Tennessee. After she was discharged from the hospital, she was transferred to one of United's in-network facilities, and it quickly became clear to me that Mom probably wouldn't live long if she stayed there. For one thing, the staff didn't seem to be making much of an effort to get her to be able to walk again. As a consequence, she was in bed much of the day and night and developed pressure sores that, as you all know, can lead to infections and are challenging to treat. They can and often are lethal. At one point, a nurse at the facility told me that I should begin getting Mom's affairs in order because the infections likely would kill her within weeks, if not days. Well, I did some quick research to see which facilities in the region had the best quality scores and arranged for Mom to be transferred to another skilled nursing facility about 30 miles away. The problem was that this new facility was not in United's network. So I had to help Mom switch back to traditional Medicare, which doesn't have proprietary and inadequate provider networks. Almost all doctors and facilities participate in traditional Medicare. The care team at the new facility went to work right away to address the pressure sores and to get Mom back on her feet. Mom will go on to live almost another 10 years. The stat story goes into great detail about how United Health uses algorithms to determine how long a patient can get coverage for a stay in a rehab facility. The patient stories are heartbreaking. They also show that appealing a denial is often fruitless. It's important to note that Nava Health, which is owned by United Health, is also used by Humana, maybe other companies as well too. Humana, where I used to work, has the second highest number of private Medicare enrollees behind United Health. It's also important to note that United Health markets its private Medicare plans in a long-standing partnership with AARP. You can turn your TV on for a few minutes today, and you likely will see an AARP United Health ad. That's because we are in the midst of open enrollment, when seniors have a window of a few weeks to pick among traditional Medicare and a bewildering array of private Medicare plans. People don't really know what they're choosing in many cases. The ads never mention any of the many potentially deadly side effects of enrolling in a Medicare Advantage plan. As the Washington Post reported today, they report today about that class action lawsuit that I mentioned earlier. That suit alleges that United Health knew that the algorithm it was using had an extremely high error rate and that it denied patients' claims knowing just a fraction would file appeals to challenge the insurer's decisions, and I knew this too. Very few people take the time or even know that they have the right to appeal. It's an arduous process. If you're not well and you don't have someone to advocate for you, it's just not going to happen. The lawsuit notes that the family of one of the plaintiffs did appeal United's denials without success and had no choice but to pay up to $14,000 a month out of their own pockets in order to continue providing care for the elderly man's skilled nursing care. Now, that story was about Medicare Advantage. But I want you all to know that if big insurance companies are cheating taxpayers and the elderly and disabled out of life-saving care to boost profits, they're doing the same thing to people enrolled in their commercial plans. In fact, ProPublica a few months ago published an expose of how Cigna, where I used to work, built a system that allows its doctors to instantly reject a claim on medical grounds without opening the patient's file, leaving people with unexpected bills. The reporters found that over a period of 2 months last year, just 2 months, Cigna doctors denied over 300,000 requests for payments using this method, spending an average of 1.2 seconds on each case. Folks, I doubt that anything that I've said today really shocked you, because you all know that big insurance companies continue to confuse their customers and dump the sick, all so they can satisfy their Wall Street investors. In the years since I first said that, Cigna and United and the other big carriers have become massively bigger as they have moved aggressively not only into government programs like Medicare and Medicaid, but healthcare delivery and the PBM business. This is called vertical integration. Cigna now gets far, far more revenue from its PBM than it does from its health plans. CVS Aetna now gets more revenue from its PBM than it does from its Aetna health plans or its 10,000 stores. And they are all laser focused on getting more and more of our tax dollars because their commercial business, quite frankly, has stagnated. We say, you hear politicians talking all the time, that 150 million Americans get their coverage of their workplace, and that's true. You could have used that exact same number in 1990 because we've seen more and more people are not able, more and more employers are throwing in the towel. They can't offer coverage. Less than half of really small employers offer coverage anymore. They just can't afford it. So it's not a growing business for these guys. That's why they're going so heavily after government programs. What this tells you is that employer customers are not nearly as important to big insurers as they used to be and as they were when I was in the industry. They are essentially treating their employer customers now as stepchildren. Now, if there's a silver lining to these pretty dark clouds, it's that this provides an opportunity for all of you here today, in my opinion. You have, in many cases, I think most of you have come to understand that employees do not have to hop in bed anymore with these big companies. Many of you have proven that. But I didn't know that until recently. I've just fairly recently become aware of what you all have done and what you're doing. So I want to help this movement grow, if I can, by using my newsletter, my advocacy groups, to help tell your story and to help you scale this remarkable work that you're all doing. I'll end with this call to action. Let me know how I can be of service. Thank you. And I think we might have a few minutes maybe for questions.
Any questions for Wendell?
Y'all don't have any questions today.
Okay, come on, Dave.
Hi, Wendell. So I'm going to give you one of my favorite questions because it's something that we see an awful lot. By the way, I'm Dave Olsner from Centivo, and one of the things that we hear all the time is how tough change is in healthcare. And I've got my whole litany of what I would call the good and the silly responses as to what or the reasons for not making change. So I'm interested in your thoughts. What are the and maybe I'll stick on the silly side. What are the worst excuses you've seen so far for not making change in healthcare?
Well, and some of it was mentioned on a panel today, the very good panel. When it comes to public policy, it's really hard because of what I said earlier, what I used to do for a living. And there are plenty of folks replaced me when I left, and they're paid really quite well to try to keep any reforms from happening that might interfere with profits. And it's not just insurance companies, it's pharmaceutical companies, big hospital companies, there are trade associations like AHIP and the American Hospital Association, big pharma, and money in politics. These companies spend enormous sums of money. One of the things my staff did was dole out campaign contributions. And we gave money, and they still give money, as much to Democrats as they do Republicans. They pretty much own Washington in many cases, and it's not just Congress. They're able to influence any administration, Republican or Democrat, and the regulatory system is called regulatory capture. So that's one big thing. That's a real thing. I don't give up on public policy. It's absolutely important to have a presence in Washington and state capitals, if for no other reason than to try to keep them from doing bad things to you, and to make it more difficult for you all to scale, to grow. And you must know that if BUCA gets annoyed with you and thinks that you're about to take some market share, they're going to come after you one way or another. And sometimes it'll be in the halls of Congress to do that, to make it more difficult for you to thrive. So you gotta I know a lot of folks are cynical about politics for good reason, but you got to play in it, or you may get crushed. In the private sector, I think there's just the belief that you guys aren't real, that why haven't I heard about this before, or the concern of, as we said, changing an employer, making a change that employees might like. But heck, I was part of the effort to usher in consumerism, consumer-directed plans, and big employers and small employers got on board pretty quickly. A lot of employees didn't like that either. So I think it's a bogus argument, or at least they need to remember that they've had to impose changes over time. Maybe they just don't want to do it again, but maybe there's some things that we can do that can persuade employers who are not here at the table today, not here in this room today, that there is a better way, and that this can really not only save them money, but their employees money, and make sure that they get the care that they need. Also, the other thing is that employers, CEOs and others, HR people, they have developed relationships with brokers and agents over the years. They find them credible. They often don't have very much depth of understanding of health care. So they're pretty easily bamboozled. And again, as a former propagandist, I really know how easy it is to mislead people, and that includes CEOs and CFOs and HR people.
So thank you.
Thank you very much. Thank you. And thank you, by the way, to BHCG and Centivo. I truly am incredibly impressed with what you all are doing. Thanks very much.
Well, good afternoon, or actually it's evening now, isn't it? So I do want to start by just saying how happy a day this is for the Business Healthcare Group, and how joyous it is for me, and how thankful I am for Jeff's leadership in keeping this going. You are doing great work, and the providers and the business community, it's really up to you to keep this going. So I just want to say that. And I have the honor to provide this award, the Paul Purcell Leading Change, Creating Value Award. And I'd like to comment a little bit about Paul. Lisa made a comment about his leadership and his vision, and he truly was a visionary. And what was interesting to me is he readily gave me his cell phone, and he said, "Diane, you can call me anytime." And he would frequently call me. And so he was always available, and it's so fitting that this award is in Paul's name. So it is my distinct honor and privilege to present this year's Paul Purcell Leading Change, Creating Value Award to Sojourner Family Peace Center. Based in Milwaukee, Sojourner is the largest nonprofit provider of domestic violence prevention and intervention services in Wisconsin, helping families affected by domestic violence achieve safety and well-being. The health of women, children, and families is essential to their work. As a responsible corporate citizen, the Business Healthcare Group strongly supports the work Sojourner does for this community. In appreciation of this work, Sojourner was selected as the recipient of the proceeds of the Business Healthcare Group's 2023 golf outing. Accepting the award on behalf of Sojourner is Carmen Petrie, President and CEO. Carmen, please come up to accept this award.
Thank
you. Hi, Jeff. Thank you. Carmen from Sojourner. It was such a privilege to be sitting here for this conversation. So thank you. I share many of the values of BHCG. And I was thinking about our own employees and our own struggles around healthcare. I can't pay people enough at Sojourner in a nonprofit framework when they go home at the end of the day worried about a client who might be strangled or killed or, someone who needs support or housing. But healthcare is one of the ways that I can take care of the people that work at Sojourner. So it was a privilege to sit here and hear the conversation around well-being and investing in people. And the quote, it's our duty to invest in improving quality and well-being. So I want to thank you for this award on behalf of the 100 women and men who work at Sojourner day in, day out. Our mission is to transform lives impacted by domestic violence. In addition to everything you said today, I would add there's another opportunity that you have as healthcare providers. We serve about 7,000, almost 8,000 individuals a year. And we believe that's just the tip of the iceberg. There are far more. There are thousands of people who are our friends, our coworkers, who we worship with, who we work with, who are struggling with violence in their life. And they will never come to Sojourner because they don't feel safe, they don't feel comfortable, but they will be sitting in your healthcare arenas. So I was sitting here thinking about not only the employees, but the thousands and thousands and thousands of people who need you to be in partnership with programs like Sojourner, because you could be the key to opening a door to safety. So I appreciate the primary care model. I would have another call to action, ask you to educate yourself about violence in the lives of the people that you see, integrate it into your everyday practice, become comfortable with asking about it, because you could be the only person that does and could be the key to safety for thousands of people. At Sojourner, we have a philosophy of no wrong door. Just today, I walked out of my office, and there was a young woman who was homeless and hungry, and we got her some food, and even though she was not a survivor of domestic violence. We've had gentlemen walk in with parking tickets, and we just do our best to see humans as human beings and give them love and dignity and respect. And we could not do that, Jeff, without the support of programs and the event you did for us. The resources that were raised at that event helped us and continues to help us provide quality care for the people who need us. A young woman spoke at that event, Jennifer, and we have thousands of Jennifers that we serve. She said something that night at the golf outing. She said, the hardest thing about the violence in my life is my ex-husband left my child, who is now an adolescent and involved in sports. She said she left him to navigate the conversation with his friends and the other families that we are engaged with. And he gets often asked, where's your dad? Why is your dad not here? So she talked about, it was very profound to hear her say that, the ripples that violence causes in our lives. So it's a privilege to be here, to have heard all the comments. Thank you to the keynote speaker, and I hope to stay in partnership with all of you. Thank you.
Janet? Anna? Please? Todd? Please?
I would like to take the opportunity to share with you And many of you know Janet, and have worked with her and recognized the passion and devotion and perseverance that she brings to her work. And every once in a while, I'm fortunate enough to make a really good decision at Northwestern Mutual. And that moment, or one of those moments, happened several years ago when Janet accepted my invitation to join us at Northwestern Mutual in our pursuit to continue to change healthcare for our members. And we recognize that at Northwestern Mutual, but that is now being recognized by the Business Journal. So members and individuals in this audience nominated Janet for kind of her leadership in the space. And I invite you to join me in congratulating Janet for her well-deserved recognition. So Janet, congratulations and thank you. I'll also say, just to add to that, like at Northwestern Mutual, we've long held the belief that our employees and their family members are very deserving of the highest value healthcare in our community. And we've talked a lot about change today and courage, and I think we find the courage to drive this change for the 35-year-old mother of two who was recently diagnosed with breast cancer, who needs to know that she's getting the very best care in our community. We find the courage for this change for the family that has a teenager that's experiencing knee pain, but yet they don't have the disposable income necessarily to pursue that health care and need to know that there's not waste in the care that their family member's getting because they're worried about not only putting food on the table, but also being able to get that teenager the care that they need. And so that's how we find the courage. And I also want to thank our fellow employers in this crowd, the Business Healthcare Group, Centivo, and all of you for your partnership in driving change in southeastern and eastern Wisconsin, because it's critically important. So thank you.
I know you all probably didn't expect to see me back up here, but since Janet was kind enough to introduce me, I just want to say congratulations, and that the work that she's done, deserving this award, is so impressive and indicative of what can be done and what BHCG and member organizations are doing. So congratulations, Janet.
Thank you. Thanks, Todd, so very much. I get to close this out, and I know I am the only thing standing between all of you and a little socialization and libation. But I wanted to just close by saying I do really recognize very deeply that the recognition that I'm receiving could not be possible without the coalition, my peers on the executive steering committee, the provider community, and we have a ton more work to do. So we look forward to continuing to collaborate with you intellectually and professionally and really making a difference here in Wisconsin and hopefully nationally at some point. So thank you very much.
Okay, two last words, well, maybe more than two last words. So first of all, I'll be remiss because I forgot to recognize Jennifer Lemire. She's a senior project manager that supports me on a day-to-day basis. Jennifer, will you please stand up? Without Jennifer, trust me, without Jennifer, none of this gets done, absolutely zero. And then furthermore, Dave Ostendorf, who is standing in the back of the room, is the chief actuary for Centivo, And in addition to that, Dave has been a strategic consultant for the Business Healthcare Group who has assisted many of the steering committee members that I recognized earlier, and for prior and current, and we're looking, and we truly are looking for a very bright future, especially in 2024 with the growth that we're going to achieve. Now, with that being said, if you turn your name tags over, there are 2 drink tickets in the back, and then there's also a ticket for raffle baskets in the back. So thank you very much, and again, thank you for taking time out of your incredibly busy days and supporting our organization and the business community in trying, and the health systems and provider groups in moving forward a reduction or trying to impact cost efficiency and quality. So prior steering committee members and current steering committee members, could you go against the wall over there? And because we're going to take some pictures. And the rest of you, go and have cocktails. Thank you.